Sorry. 10:29. I don't know if you're gonna wait till it clicks over.
Okay.
Okay. So it's 10:30.
Okay, all right, so let's go ahead and call our meeting to order. Thank you everyone for joining. Hold on.
I'll do a roll call. Thank you, Shelley. Amber Wright. Here. Brian Smith.
Present.
Chester Key. Jason Johnson.
Here.
Chris Ramos.
Present.
Chris Long. Matt Shaw.
Here.
Orlando Alcordo.
Present.
Ryan Harold.
Present.
Sandy Nygaard.
Present.
Sharon Hollenberg.
I see her on her too.
Sharon, whenever you want to do a mic check, please interrupt. And then Stevie Merrill. I count 9. We have quorum.
So moving on to the chairman's report. First, I have the attendance report, which is attached with your agenda or in your packet. As a friendly reminder, if you miss more than 2 meetings, the Bureau will contact you to make sure that you're still interested in being on the committee. So thank you all that have joined today. Next on the chairman's report are new members. So we are welcoming 1 new member, Jason Johnson. So he's here today. Do you want to say hello?
Hello.
Tell them how far you drove.
Well, I drove down from Sholo last night, so.
Well, it's good to see you in person.
Thank you for that.
But I forgot it's July down here. I should have just called in.
Yeah, tried to tell me it was hot in Flagstaff. I was like,
We were 90 the other day. I think we were like 88 or 89. It was rough.
Okay, vacancy report. We have 1 vacancy for NAEMS. So if you want to contact info@naems.org to apply for that vacancy. Moving on, our next section is the Bureau report. So I'll turn it over to Chief Garcia.
Thank you. Good morning, Dr. Rice and members of the committee. I'll give some brief introductions to some of our newer staff that are joining us both in person and virtually today. We have Lehia Castro, who has just accepted a position with Bureau. She is joining us virtually this morning. She is a new project coordinator senior that will be helping us to implement the image trend licensing management system that we anticipate will replace our certification system online in 2023. More info to come on that. We also have in the room Adam Rodriguez, who I know many of you have met already. He is our EMS coordinator and juggling several things for us right now at this point in the year. And to my left is Marissa Salvato, who again, I'm sure many of you have met already. She is our base hospital manager. And great liaison, great background. We look forward to you all working with her more as she starts attending some more meetings out in the community. We also have a few promotions within the Bureau. Taylor Pike has accepted a new section chief position over ambulance programs, and Noreen Adlin has accepted a new section chief position over trauma and pre-hospital coordination here in the Bureau of EMS. Shelley, want to acknowledge you one more time as well in your program specialist position, keeping us on track with all of these meetings. We really appreciate everything Shelley does for the Bureau as well. So a few quick updates before we jump into the agenda. Thank you very much to National Registry who has joined us today for some updates and some good discussion. We'll turn it over to them here shortly. But before that, this morning we did have our TEPI meeting that talked about the fact that we will be looking at a new trauma registry in the next year. And we are also getting prepared to migrate to BEMSTS version 3.5 for all of the agencies that are currently reporting through electronic PCR systems. So please keep in mind that those transitions are coming in this next year after July 2023. We also, following this meeting, will have our PMD group come together to look at the T3Gs. And that group has the goal of refreshing the guidelines and pushing those out to everybody by 2023 as well. There are several legislative and rule updates that we'd like to come back and provide information on at the next EMS Council meeting in September of this year. The general effective date for many of the EMS bills that did pass this session this year is September 24th. So we will certainly have some time to talk about some of the new legislation before it goes into effect. For awareness, House Bill 2431 on EMS transportation, House Bill 2407 on ambulance mileage rate calculations, and Senate Bill 1210 on transportation for court ordered treatment. Those bills go into effect, general effective date, again, which is September 24th of this year. House Bill 2609 for ambulance services and certificates of necessity, that is a delayed implementation date. That bill does not go into effect until January 1st, 2024. So we will again come back to EMS Council in September and provide some more in-depth updates. We anticipate that with all of the EMS bills that ran this year, that we will be doing quite a bit of rule writing. And so we'll look forward to meeting with the stakeholders and talking more about our rule writing efforts in the coming year as well. I think that's all I have for now. I will turn it to Dr. Bradley next for naloxone leave behind updates.
All right, good morning, everyone. Thank you for joining us today. I will keep this brief as we do have a heavy agenda for the Education Committee. Just a reminder, in the agenda packet, there are 2 links to the naloxone leave behind program as well as the ADHS opioid website. There are quite a few resources on there, specifically for EMS. We do have the educational curriculum that this committee put together for naloxone leave behind program, as well as a standing order and a template pamphlet. So if you have any questions about that program, please feel free to reach out to me. I will put my email in the chat, but in the interest of time, we will keep moving down the agenda as we just have a busy agenda today. Thank you.
All right, thank you very much. All right, so moving on, we have quite a few discussion and action items today, so we'll try to keep things moving along. The first discussion and action item will be to discuss, amend, and approve the minutes from the March meeting. So if I can have a motion to discuss. Or a motion to approve. Is that Matt?
Ryan.
Ryan, thank you.
All right, is there any discussion on the meeting minutes at all? Great. All in favor of approving the minutes, say aye.
Aye.
Any opposed, say nay. Great, thank you very much. The second discussion and action item will be to discuss, amend, and approve forming a work group to create training on the ACS field triage guidelines updates. So with the new changes to the ACS field triage guideline, there has been some discussion about creating some training that would go out. I know the ACS has already created a fairly extensive packet for training. So this would likely be to sort of probably make that a little more friendly, right?
Yes, the ACS has put together some really nice training curriculum in terms of how they develop the actual updates to the ACS field triage guidelines. I think the ask from staff for this group is to consider putting together an Arizona-specific training curriculum. There really are some key nuance points in the update that will need to be educated as that moves forward, specifically evaluation of patients with ground level fall, head injury, anticoagulation use. And so the request from staff was to have this committee potentially put together that training PowerPoint. We can certainly utilize what's being put together by ACS as kind of a foundation, but then really try to expand in those areas that will need further education, with the hope that if that can get approved at the November meeting, this will be a resource for agencies to use statewide, starting in 2023 when the TTG are updated with that. So that is the ask for this group. This group is willing to take that task on.
All right, can I get a motion to discuss this action item?
So moved. That's Sandy.
I also captured Matt with a hand raised.
So is there anyone that would specifically be interested in working on this particular work group? Obviously, we could take volunteers, and obviously offline work on much of this.
Brian will.
Sandy will too.
I'm sorry, did we vote to approve it?
Huh?
Did we vote to approve it?
Not yet. We have a motion to approve a work group.
And we have 2 volunteers, Brian and Sandy. Okay, I'm tracking.
Are there any questions about kind of the ask from staff for this group? Yeah.
I guess we'll take this one to a vote. All in favor of approving a work group to create some training for the ACS field triage guideline changes, say aye.
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 Any opposed? Great, so you can send names to Shelley or myself if you're interested in working on that work group. Typically with the work groups, we will do much of the PowerPoint creation sort of online or offline, and then we'll come together for a meeting, maybe to sort of finalize the PowerPoint and go over any things that need further discussion. Next action, or this is actually just a discussion item, the training program and NREMT update from TJ.
Good morning. I'm going to do my best to not steal any thunder from Josh or Megan or any of the folks from National Registry. But as everyone knows, there were quite a few different actions that took place at the last board meeting. And the one I'm going to touch on specifically is the resolution offering a state-approved pathway to National Registry certification that did not include accreditation. It gives you those 3 options. One is you attend an accredited program. 2, you could attend a program that had a letter working towards accreditation, and then the state one. That led to a significant amount of discussion at NSEMSO at their annual meeting. I was on the Personnel Licensure Council, and during our meetings, we drafted a position paper to submit to the main body to basically object to that perspective and that resolution that the registry had put forward. It went to the main body, who wordsmithed our document into a resolution that included some consideration for states that were attributing their staffing shortages to the requirements of accreditation standards to work with National Registry to develop a state-only option. So essentially the position that came out and was voted upon and approved overwhelmingly by the NSEMSO leadership was to offer some assistance in helping those states create a state option, which would allow their state to certify individuals, but would not allow those students who did not participate in an accredited program to sit for National Registry. So Louisiana was the only no vote against that. There was a handful of states that abstained, but overwhelmingly supported. That discussion basically led to some movement on creating some additional NSEMSO standards, where we basically set a floor or a baseline for all of the certification options within the EMS world, because we've got an incredibly diverse spectrum of certifications that exist currently within the states. One of the other things that was going along with that is a discussion from the AVL committee about the concept of ambulance driver, and that's the word a lot of individuals were using. Staffing for ambulances as far as drivers go is varied as well. We've got some options in the state of Arizona, depending on the population count, wilderness designation, where in theory an EMR could be an ambulance driver. with an EMT in the back. So across the spectrum, you've got areas where you've got a double medic ride, some areas where they have somebody who may or may not have a valid driver's license, and that's all the training they've got, currently serving as 50% of the staffing for an ambulance. So there's a broad spectrum there, a lot of discussion looking at leveling the playing field within the nation as a whole to try and set a baseline for standards for all of the different certification periods. One of the items that we've got in Arizona, which we're going to need to look at in rule, is returning to a certification option for EMR. We still have several programs who are certified by National Registry to provide that training and have their students sit for EMR certification with National Registry, but we don't have a state option for that. And that's the only one of the 4 that we don't have an option for. And if you kind of look at the standards coming out of the EMS agenda for the future and the blueprint for the national scope of practice, essentially it's almost the reverse of the Russian nesting doll, where I get it. An EMR has got a little bit of information, a little bit of education, some small level of scope of practice. And as they continue their education, they go with additional knowledge and additional skills and require additional certification to advance. So they get more information, more comprehensive levels of clinical judgment as they advance through the EMR to EMT to AEMT if options are available to paramedic. So one of the things that's going to be on the future is looking at a potential of adding that. Again, there's a pretty diverse scope as far as the education programs are concerned for EMR. They'll range from sometimes as low as 45, 48 hours up to 100. And there's no real rhyme or reason to how they're established other than the folks that are actually following the standards that were issued by NHTSA. On the accreditation side, again, National Registry just reached out to NSEMSO to put together an advisory committee, and that's going to consist of all of the regional representatives, the education chair for the education committee, and the PLC chair from the Personnel Licensure Council to help work with them on the accreditation topic as well. And with that, I will turn it over to the folks from National Registry that are here to provide some updates. I know I saw Megan, and I think I had a phone number for Josh. Not sure if Steven made it, but I will turn it over to those folks.
Hi, TJ. Thank you. This is Joshua Tilton from the National Registry. I'm on the Stakeholder Partnership Group. Forgive me for calling in. I'm in Minnesota this week, so I have to be remote. But you gave an excellent overview of Resolution 2213. But one of the main things I just wanted to touch on is that this resolution is a draft. So public comment period is open, and after the public comment period, it will be reevaluated by the board. But I'm happy to answer any questions, take any comments or feedback that you guys have. I assume you've all had a chance to read the draft resolution as it sits.
Josh, one of the things that I didn't want to steal from you guys was the update on the distributive education. So I don't know if I'm pretty sure I saw Megan in there.
Yeah, I can help you out.
Megan.
Yeah, so I'm Megan Hollard. I'm the certification director for the National Registry of EMTs, and along with COA, there's a bunch of other changes going on too that came out of this June Board of Directors meeting. You know what? With the COVID pandemic that occurred, we did remove temporarily the distributive education limits for the NCCP model, and this included everything for recertification and the requirements to recertify. So we've done that since we scrambled March of 2020 to remove those. And the board just kept renewing that as the pandemic kept going on. And that's just kind of the shift that occurred. You know, ultimately with the collection of data that we have, the education that was reviewed, and speaking to our stakeholders, we also have, keep in mind that this is a draft resolution that is available for public comment. So the recommendation is to remove those distributive education limits for the NCCP. Please note that National Continuing Competency Program, those NCCP requirements also impact the state licensed entry, and then National Registry re-entry pathways for initial certification. So if somebody expired or lapsed, they would do the NCCP model or the refresher for the NCCP and be able to come in and be eligible for testing. So it impacts both recertification and initial certification pathways, which is different than the pandemic. What we want is to strive for consistency within the organization and our standards. And so with that, please note that we will always accept 100% in-person classroom education. But this just shifts and allows that distributive education and F3, CAPC F3 unlimited. So know that you can do pretty much any form of education, any method of education, and it will be accepted now according to the draft policy. There is if you haven't checked it out yet, policies for public comment on the National Registry's website. There is a running bar across the top, a banner. So if you click on the banner, it's a very quick and easy way to get there. There are 4 resolutions open for public comment. The first resolution is for that remote proctoring. It's resolution 2201. What this says is that, you know, National Registry, depending on assessments of risk, are able to offer remote proctored examinations. We have been doing this in the past. Since the pandemic, we were able to quickly transition to try to keep certification going. We needed providers out in the streets, right? So we've determined that this has been pretty successful. We've worked with Pearson VUE and OnVUE to deliver these examinations and created, analyze the risk from that. And so that is the resolution. The recommendation is to keep that going. The next one is the distributive education. So that is 22 Resolution 06, and it's the removal of the asynchronous distributive education limits or distributive education. So the availability to do all online or unlimited amount of F3 type education. The next resolution available for public comment is the practice analysis addendum. This is 22 Resolution 09. This is moving into basically the ALS redesign, if you've heard that. So this basically comes into play with an addendum part. So we do the practice analysis, and this is an addendum to that. It basically says that we found a need to include domains of clinical judgment, leadership, and communications as part of the ALS EMS clinical examination process. Along with that, and as you're familiar with, the last resolution is 22 Resolution 13. This is the update to the eligibility criteria, which is the COA that we've all been talking about. So keep in mind, this does impact what we call the certification schemes, or our policy for entry into the National Registry for Examinations, their eligibility or entry requirements. So that is what that is. There are 4 resolutions available on our website for public comment. I will tell you that I review and reply to every single public comment that comes in. I document, I record them, and I make sure that our board is seeing your public comments. It's visible, analyze the data on those coming in. So absolutely, I welcome every single one of your comments on all those public comments there. Any questions I'd be happy to take?
I'll just kick off the statement. This is Gail Bradley, Medical Director for ADHS, Bureau of EMS and Trauma System. We got quite a bit of feedback in the last 2 years, really regarding the limits on distributive education and the challenges in getting education out in person, and how beneficial this change was over the course of the waiver. And so I have provided that feedback on behalf of stakeholders in Arizona to National Registry. So we do appreciate that you made that resolution. So just really want to ask anyone who's here today or on the meeting to please make sure you share your views on that in the public comments. Link is in the agenda for anyone who does not have it. You can click on the link that Shelley provided. We'll take you directly to the National Registry website, and then you just pick the resolution. So I just wanted to say the feedback that this committee provided over the last 2 years, we did provide to National Registry and it was acted on. So thank you.
Yeah, very, very welcome. And we're at, like I said, please, I implore each one of you as individuals also to do public comment. It does not have to be on behalf of an organization or a state committee or anything. This can be on behalf of you and your providers, your colleagues. And so please feel free to comment. Every single one of those is answered, reviewed, and we do value your input.
Great, thank you very much. Does anyone else have any other questions for Megan or Josh, who are still on the line? All right, great. Thank you guys very much for joining and providing some of your input. The next item I have on the agenda here is to discuss, amend, and approve training curriculums for the STR skills. So if you look at attachment 5.I, and we certainly can take a motion to discuss this as well. Do I have a motion to discuss?
So moved.
Yeah, great. So if we look at the education training module, so the top part we've had previously, and we've tracked the update with the goal of reviewing every couple of years for each of these different training modules that we've created. In addition to that, there's a small section that has some future ideas for things that we might create work groups for training curriculums for. And then, as was discussed previously, the special training required curriculum. So we've worked already on, some of the epinephrine related ones and the Untitled CO2 trainings. And so this would, looking at the rest of the list, we felt like we could potentially combine some of these. And so this would really kind of be the full list of everything that would be required additionally to cover all of the STRs that we currently have. There would be an EMT airway section, supraglottic airways and CPAP, which could potentially be combined. Initiation of IVs and maintenance of non-medicated fluids as well. And then some of the other ones that might require a little bit of additional discussion or maybe put on later, just relative to the amount that they're actually probably used, would be things like urinary catheterization, transport vents, potentially infusion pumps and thrombolytics. So,
Turning the volume up for people who are having a hard time hearing you.
okay, speak to the light. Okay, so any further discussion on any of these or any motions to create specific work groups for these? I think the top two are probably the most utilized of the STRs, I think, in my experience. Some of the other ones probably much less so. But certainly would be open to at least starting with the creation of work groups for those first two items.
Are you thinking for like CPAP and the automated transport ventilator, those would just be basic concepts? I mean, a lot of training would be specific to like the machine that each agency might be using, which would be pretty different.
Yeah, I think so. I think it would be like physiology, A&P background, some of that related stuff, indications, contraindications, specific use of things that the agency specific. Okay.
You added like Untitled to it as well?
So we have a capnography one.
Right, I just didn't know if you'd combine it or just keep them this separate.
We certainly could combine it with that, absolutely. We could keep them separate or combine them. I just thought if folks are going to get together in work groups, maybe we would combine some of the related items and work on them together. a need to create these. In the last meeting, there was some discussion that we should create some baseline education for these specifically because we have outlined them as skills that require special training.
Yes, so the history and background on this, there is a couple 100-page document that is an outline document for STR training. So the rule writers felt that if we have STRs, that there should be training available on the website. The current training that is available for the majority of the STRs is
Not really training.
it's not training. It's basically a 200-plus page outline of what a training could look like. This committee has put together already some training curriculums for existing STRs. So I'm epinephrine for anaphylaxis for EMTs, Untitled CO2 for EMTs as well. And so the ask was, do we want to actually look? So this group had kind of gone through all the STRs with scope of practice update and had come up with the actual list of what are the STRs that are left. I will provide some data at the bottom about thrombolytics. Based on the data and usage of thrombolytics, we do not need to create a training curriculum for that one. But this was kind of the way that the group had looked to see how could we narrow the focus. So essentially, we'll be creating, 4 or 5 additional training PowerPoints that agencies could actually utilize versus the multiple 100-page document that is probably not a useful document for agencies and their medical directors to use. So that is the history and background as to what the ask is. So certainly with the fact that the trauma one would likely be a priority training, I think it's reasonable to start with one if the group wanted to, and then kind of see how that goes moving forward.
I'll apologize because of my ignorance since I'm new to this, but so I really like the idea of doing these. The one I don't know if we get much use out of is urinary catheterization. So when we do those, it's for our hospital-based providers, and they have their own. Actually, the nurses do all the training for it, and it's not. So I don't know if that would be really useful, but I definitely think the first 2 would be super useful.
So one option for that one would be to simply, if someone has from their hospital a training PowerPoint that's together, that could be adopted by the committee as an option for use as here's what we feel is a reasonable training for paramedics working in a hospital setting doing this STR.
Yeah. My initial thought would be to start with the ones that we know are utilized by a large number of agencies and providers, which would be particularly the supraglottic airway, CPAP, and the IV-related ones. That would be my initial suggestion, or even just picking one of those to start would be, I think, fine with the intent that we move on in a future meeting and continue to work on this.
How do you guys normally do? Do you do like one per or per section, or and then review it, or?
Maybe on average, we review or create one.
For me, I would say try the airway one because I know that's fairly standard.
Is that your motion?
Sure, then we'll do that. Yeah.
Okay, we have a motion from Jason to do the airway SDR work group. I have a second for that.
I'll second that. And I'm happy to help with your motion.
Everything. Okay, so all in favor of creating a work group that would address the STR for EMT airway skills, supraglottic airway, and CPAP, say aye. Aye.
I see Chris Rollins has his hand up. I wasn't sure. Chris, are you volunteering?
I guess both. I'm in favor and volunteering.
Oh, great.
I am also in favor and volunteering if you for supraglottic and CPAP, and vent if you need that as well.
Sorry, can you say your name, just who spoke up that you were willing to participate?
It's Angie Ropicki.
Thank you.
Okay.
Thank you.
Awesome. And anyone else on the line or within the committee, feel free to send over your name and information. Start putting together that work group.
I did put in the chat for anyone having audio issues. I did connect my headset to see. You may get better audio quality if you use a headset. Using the headset, the audio does appear to be loud and clear. So if you're having difficulty hearing us, we apologize. But you may want to try your headset to see if that does help your audio.
All right, moving on to the next item was to discuss amend and approve a report from a work group to review LifeVest resources. So this item, both Matt and I had reviewed the LifeVest resources. No one else had really volunteered to look at it, but Zoll didn't seem to have any updated information on their website related to this. So the work group did not have any recommended additions or changes for that specific educational document that's on the website. So I don't know if there's any actual action to take on that, except for maybe to.
It is a recommendation to make no changes.
Yes, I guess the recommendation would be to make no changes. So.
For the 2 years.
For another 2 years, yeah. So,
I think that could be, yes, there's a motion. I think that could be a motion to approve, and then that would be the update date would be today.
perfect, great. Can I get a motion to approve the current resources for the LifeVest for an additional 2 years?
Ben and Matt are throwing hands signals.
All right, all in favor, say aye.
Hi.
Aye.
Any opposed? Okay, great. And then the next one is for the Stop the Bleed resources, to discuss them and approve or update, the update for those. So in reviewing this, there also wasn't really significant amount of changes that were related to this, but there was one recommendation out of the committee, and this came from Matt, to add an additional just link to the site talking about compressing the zones of care. I don't know if you want to make a little bit of discussion on that. There wasn't really much, but okay. Yeah, there's just an additional link on there that just gives it a mnemonic for Stop the Bleed care. So that wasn't part of the set of links related to Stop the Bleed training, but that was the only recommendation out of the committee, was to add that. If I can get a motion to approve that change.
Brian, so moved.
Oh, thank you, Brian. And a second, great. All in favor of adding that additional link to the resource page, say aye.
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 Any opposed? Great. Thank you for looking through all of that, Matt. And then the next one, discuss, amend, and approve forming a work group to make a training on death notification. I don't know if you want to say anything about this one, Gail.
This was a request that had come up a while ago as we looked at the fact that EMS has done quite a bit of training over the years in termination resuscitation. Many EMS providers really had minimal, if any, training on death notification and how to perform that on scene. There is a training curriculum that was studied and published, although really a small number, but it did show some benefit in terms of how to provide that training to EMS providers. And so that had come forward to this group. Certainly, I think there is a lot on the table in terms of projects. I think this is a very beneficial topic to have. So it's quite reasonable if the group wants to form one. We can just have a group kind of on standby when there is time available. So the option is to just form the group if the committee wants it, and then we can have those members available once there's time to be able to do that.
I guess the motion.
Okay, stop whispering.
So,
Loud
So
crowd.
motion.
Thank you, Jason.
So is this going to be talking like to the patient's families, or you're not the patch to the?
Correct.
Okay.
Is there a second?
second.
Thank you. All right. All in favor of creating a work group for death notification, say aye.
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 Any opposed? All right, so this likely won't be a very immediately formed work group. However, if you're interested, definitely send your name to Shelley or myself if this is something that you have a passion for teaching. We could definitely use your input, and when we get the time in the agenda to put that work group together, we'll start emailing people out, set a date for that at a later time. Next item is going to be, this is our standing item. We already kind of did this, reviewing the table of training modules. So I will mostly breeze over that since I already went through the table with you guys. So take a look at that, and if you have any additional suggestions, I can take those now, or feel free to forward those to myself or Shelley anytime. The next item on the agenda will be to discuss and approve changing a 3-year cycle for reviewing posted training curriculum. So you want to talk about this one, Gail?
Yes. So this was back to the what Shelley's displaying right here. Initially, we had decided on a 2-year cycle for update. What we've recognized is that several of these topics, really nothing has changed in a number of years. But as the volume of educational curriculum has increased, we would like to consider going to a 3-year cycle. Certainly, if something significant comes up, which we have had in the past, we would update this before the 3-year cycle. So the 3-year cycle is a minimum that we would hit, and that's the recommendation and ask for this group is to approve that. That being said, if something were to come up and they say tomorrow, here's completely new recommendations for life vest, we would absolutely look to update that. So we can always do it more frequently, but the minimum would be every 3 years instead of every 2 years.
Yeah, I would be supportive of that. Over the past couple of years, the ones that we have re-reviewed have yielded very limited changes, especially significant changes in the content, because much of this is core content. So I would definitely be supportive of that as well. Any further discussion?
It's Brian, I'll make a motion that we move to 3 years on review.
Great, thank you, Brian. Do I have a second?
This is Sandy. I'll second that.
Thank you, Sandy. Okay, all in favor of moving the review cycle from a 2-year to a 3-year cycle for our posted training curriculum, say aye.
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 And are there any opposed? Okay, great. Next item is going to be a discussion item on this to collect feedback for PACE's draft training about pediatric behavioral emergencies in the pre-hospital setting. Do I have anyone from PACES that's here to discuss that? Oh,
Dr. Rice. So this is from a PACES work group, the behavioral health work group. This was in response to the Arizona short report that showed an increasing number of behavioral health incidences in Arizona across all patient demographics, as well as the pediatric demographic. And so the group produced this in quick response to that. We thought it might be beneficial to bring in front of the education community today for a couple of reasons. One, just so we can get more eyes on it. And two, so that we can kind of take advantage of the fact that the PACES meets just after this, and so any change we make in PACES has to wait until the next series of council meetings to incur any feedback or changes. So we thought we might just kind of usurp that time and see if we could solicit any information here in the room. Specifically, well, have a look at the entire thing, but specifically for each region, if they could have a look at the slides where it says to local resources. I would like to lean on the different regions the ask is to provide me with knowledge of your local resources. Sorry, it's the slide says transport at the top of it. My apologies. And that's the specific ask is can you help me identify those resources within your region that make this specific to your region? So that would be great. And the third goal of this is to expose the education committee expose this to the education committee so there can be some sense of a heads up. So it's not completed it over their paces and then we wait 3 months and it's shipped over to you and then you're having to deal with it all sight unseen right then. So that's the idea here. So if anybody has any feedback on this as a generality or within that particular slide, I'll put my name in the email or if you need some time to think about that. But otherwise, I'd like some of your thoughts.
You can, the one input I had is if you can scroll up to the data graphic slide, so it's that one. That's an excellent slide. My only comment would be to include the source of that data on the slide as a footnote, because I think people would want to know where that data is coming from. So that would be my biggest feedback on that one, is add the source for that data. The infographic is great. I think it's a very telling picture.
That is from the short report.
Pardon?
It is from the short report, but I'll make sure to update that.
And then as far as local resources, are you saying outside the emergency department?
Yeah, what I'm trying to do is just tease out all of the resources that within a region might be specialized to that region or only known to people within that region or pre-hospital providers within that region. Just to kind of help me round out an internal investigation to what the state has out there in terms of behavioral health resources, specifically pediatric.
So I could tell you for the White Mountains and the northeastern part of the state, there's no pediatrics. 100% all go to the emergency department and 100% are transferred out.
Okay, and
so this would be the same for most of our regions. It'd probably be almost none of them would primarily transport pediatric patients to anywhere else. And those resources do change on a fairly frequent basis, especially for pediatrics.
Surely, and that makes sense. That's aligned with what we're seeing is one of the motivations for the creation of this is that we were seeing inordinate wait times in EDs with pediatrics with behavioral health emergencies, and so they're there for days at some point, and that's just not the appropriate place for them. And so, if I can collect as much information as I can to start to have a look at what else can be done, is essentially what I'm doing there. So
I think that'd be great. I know in ours, basically, if a kid comes in on a Friday, they're not going anywhere until it's
exactly
Monday,
that. Absolutely. So, and we've heard that echoed from many different channels, and so that's what we're just trying to, maybe the incipient phases of gathering the information needed. I mean, obviously, ideally, the answer would be a pediatric behavioral specialty center everywhere we go, but our landmass is so big, everything goes to the major cities, and it sucks up our resources, and both in the pre-hospital and the hospital setting.
Slide 15, is it still, slide 15 still in the works? Just here are some men.
Oh, yeah, so I was hoping that I could solicit some types of medications, because, you know, in the pre-hospital setting, we use a bit of their medications as a history. And so I was thinking perhaps that might be a decent approach for pre-hospital providers to see some medications. Okay, that's what we're dealing with on the off chance that perhaps that patient isn't willing to give their own history, or maybe a poor historian or something like that. And we do have the patients looking at this later on, so Dr. Ward, which will definitely provide his input there, but otherwise, still looking. Mark, what to remember.
So if people have specific feedback, do you want that sent to you?
Sure, yeah, I'll definitely put my
Like
email
your
in
name
there.
and emails on the back slide there.
Yes, absolutely. Oh, thank you. Yeah,
Perfect.
put that on there.
All right.
Can reference my email from into the slides, but I'll also put it in the chat so everybody has good contact for me. I realize it's probably a lot to ask all of a sudden to ask for that, so please just take down my information in the interest of time.
Awesome.
Yeah.
So send any of your feedback.
Thank you.
Thank you very much. And then I have one last item on here, and this is something that Gail had pulled some data on. This is another discussion item. Talk a little bit about EMS thrombolytic data use, and this speaks kind of to the need for possible training, or the not so important need for possible training.
I can definitely not take credit for pulling this data. Ann Frank pulled all this data for us. So yes, Anna's amazing and can find any data request we have pretty much. So looking at the AD peers data, we have 2021 and 2022. And so when the top blue color graph is really if a thrombolytic was listed in the treatment at all. So many times a crew will pick up a patient, thrombolytics were initiated or administered at the sending facility. Some crews will document that in their EPCR, even if they are not administering it. The second one in green, which I think is the more telling one, if we go a little further down, this is if the thrombolytic was administered in routes, so between facilities, so actually administered by EMS. And the reason we asked this question was, do we need to create a training curriculum for thrombolytics for paramedics? Because it is an STR. When we look at the use for 2021, there were a total of 3 instances where this was administered, and all of those were via air. So when we look at 2022, year to date, we are at 0. So based on this data, it does not look like we have any pre-hospital administration of thrombolytics by a paramedic. And I think it's reasonable to hold off on doing an STR curriculum, but wanted to make sure we at least presented that data. That was one of the requests when we were looking at the thrombolytics, was trying to figure out, is this being given by EMS? If so, how often? Again, we have things that are STRs in our scope of practice, and as we move forward with future scope of practice updates, this type of data may be useful to decide, do we even continue to have that as an STR? So if we see that something that is not being administered once in 2 years by a paramedic in the state of Arizona, should that even be included in scope of practice? So I think a very useful use of the data that we receive by AAC peers. So wanted to give the background on that. So I think it backs up this decision to not do a curriculum on that.
Yeah, I totally agree. Any other comments on that, or? Very reasonable. Okay, and now moving on to number 6. So, agenda items to be considered for the next meeting. If anybody has anything that they would like to be considered for the next meeting, you can mention that now or send a note to Shelley. Nothing. We'll move on to call to the public. And then our upcoming events are listed below there in the agenda. So events running from July all the way through March of next year are listed on there and can also be found on the website as well. Our next meeting will be November 17th, same location maybe? Yeah. Not sure, probably. And then with that, we can adjourn the meeting till next time.
Thank you, everyone.
Thank you.
Thank you.
Bye, thank you.